Now that I'm off mute, we'll go ahead and get started. Welcome to everyone. Good afternoon. We're very happy to have you here for our first SEICHE Center for Health and Justice Spring Seminar. We would also like to thank the Equity Research and Innovation Center, ERIC, at the Yale School of Medicine, and the Social and Behavioral Sciences Department at the Yale School of Public Health for co-sponsoring the seminar. We are joined today by Dr. Jaquelyn Jahn, and Dr. Jahn will be presenting for us on the criminal legal system and health inequities, research for action. Dr. Jahn is a social epidemiologist whose research investigates the consequences of social policies for population health and health equity. She is currently a postdoctoral scholar at the City University of New York, or CUNY, where her current projects examine the intergenerational implications of criminal legal contact for health and well-being across the life course, as well as the effects of reforms in US healthcare and criminal justice policy. She received both her PhD and her MPH from the Harvard T.H. Chan School of Public Health. Dr. Jahn?
Thank you so much for that kind introduction. I'm going to share my screen. Okay. And then, which display do you see now?
You've got the right one now. We see your slides.
Okay, great. Thank you.
And I'll be monitoring the chat. And as far as questions, do you want me to interrupt? Would you prefer that we save questions for the end? What would be best?
I think please feel free to interrupt me if there's any questions about like clarifying something I said or a question sort of, related to clarification. But I did save a good amount of time for Q&A and discussion at the end. So we can do that then. Does that sound good?
Great. So for the audience, please submit your questions to the chat and we'll ask as we go if it's clarifying, and otherwise we'll wait till the end. Thanks.
Great, thank you so much. And thank you so much for inviting me to be here today. I'm really excited to share with you some of this emerging work that I've been doing in the past year or so. As it relates to the criminal legal system and health inequities, research for action. And so my research is motivated by long-standing activist movements against incarceration and police violence that have brought national attention to these as issues both of great public health importance and of racial justice. And by that, I mean, increasingly public health evidence and frameworks have been used by both policymakers and activists to develop solutions to prevent some of the harms inflicted by the criminal legal system. One notable example of this is this past November, the American Public Health Association released a policy statement that recommended decarceration to avoid some of the health harms of incarceration, particularly during the COVID-19 pandemic, but also beyond. And there are just so many examples of this. Public health evidence informing criminal legal policy in the COVID era especially. But I think it's also really important to point out that public health evidence has mattered for criminal justice policy even before the pandemic. One example of this is from Massachusetts, which in 2018 passed the primary caretakers bill. And this is a picture of the legislative hearing featuring Families for Justice's Healing, a local activist coalition there. And they passed the bill on the basis of the psychological and economic harms of parental incarceration for families. But as a social epidemiologist, what I find particularly useful and what I think I bring to this work is social epi frameworks that help me understand the criminal legal system and how it might relate to public health. And in particular, I draw from two social epi frameworks, ecosocial theory and public health critical race praxis. And I'll just explain those both pretty briefly. So ecosocial theories suggest that people embody or literally carry within our bodies the social world that we live within. And what that means is that bodies tell stories. They tell stories about the social traumas we experience and the health opportunities we're given. And I think this theory is really useful, particularly because it encourages us to think at multiple levels and across the life course. So an example of the way that shows up in my work is I'm particularly interested in exposure to incarceration and health effects for people who are themselves incarcerated. But I'm also interested in potential health consequences of family member incarceration, as well as the large-scale community loss due to incarceration and what that means for community health. The other aspect of ecosocial theory that I think is really important and also links to public health critical race praxis is that they both say the ultimate goal of this work isn't just to document the harms of these experiences, but rather to prevent those harms from happening and to eliminate racial inequities in health outcomes. And towards that end, public health critical race praxis says that racism is embedded in the social fabric of society. And so if we're going to talk about the criminal legal system and health inequities, we have to do so with a racial justice lens. And it also says that in doing that work, we should be prioritizing the perspectives of marginalized voices. And the way that that will show up in the work I'll be presenting today is in some of the qualitative and mixed methods approaches I take. So today I'll show you how I apply these two theories with two concrete examples from my research. I'll look at two aspects of the criminal legal system, fatal police violence and solitary confinement. And then I'll look at these two exposures at two levels. First, we'll talk about fatal police violence as it shapes the health of people in surrounding areas. And then I'll talk about solitary confinement as it affects health and healthcare from the perspective of people who experience it. But before I dive into my first paper about fatal police violence, I want to acknowledge that this is a particularly difficult week to be talking about this topic because of the ongoing trial in Minnesota. None of my slides include graphic content, but if you need to step out, please feel free to do so. So this first paper is about fatal police violence and pregnancy loss. It's work that's currently under review, and it's done with this fantastic team of colleagues. And increasingly, fatal police violence is understood as a health outcome in and of itself. It's a kind of mortality that has really wide racial and ethnic inequities. The lifetime risk of being killed by police use of force is 1 in 1,000 for Black men and boys, and this rate is about 2.5 times higher than that of white men and boys. There are also strong racial and ethnic inequities between Indigenous and white men and boys and Latino men and boys versus white men and boys. In addition to the direct health consequences of fatal police violence for individuals and their families, the emotional toll of these events likely extends beyond families to broader communities. There's an emerging body of research that suggests fatal police violence is both a result of structural racism and, in and of itself, a racialized psychosocial stressor. One possible health outcome that could be affected is pregnancy loss, particularly because stressful events have been shown to alter fetal development, especially when these stressful events happen early in pregnancy, to increase the risk of pregnancy loss. So this study's two primary research questions are, first, does exposure to fatal police violence during pregnancy increase the risk of pregnancy loss? And second, does pregnancy loss Is pregnancy loss more likely for groups that are disproportionately affected by police violence and surveillance? To answer those two research questions, I use data from Fatal Encounters, which is a media and public records source data set on law enforcement encounters that end in a civilian death. And I use this data set because of known underreporting in these deaths in official federal vital statistics data, as well as in Department of Justice data. So our study included 2,500 or so deaths that occurred in 520 core-based statistical areas. And what that means is just the areas surrounding and inclusive of small and large US cities. Our primary analyses excluded deaths due to vehicle accidents and drug overdose because these, quote, accidental deaths might receive less widespread public attention and would therefore be expected to have less of a population health impact. However, I did conduct a sensitivity analysis where I brought those other events into the analysis. So we linked those death data with data from about 7.7 individual level birth certificate records for areas with at least one incident of fatal police violence during the study period. And so we define our exposure as an incident of fatal police violence that occurred in the same city or surrounding area during pregnancy. And to test these hypotheses, we used a method from environmental epidemiology. And it's normally used to understand fluctuation in air quality measures and pregnancy loss. And so what this model does is it looks at changes in the number of live births within an area and links these changes back to exposures that happen after conception or during gestation. The core assumption of this approach is that a decrease in live births after a police killing is due to an increase in lost pregnancies. So my results will sort of follow this graphic format. On the x-axis, we have gestational month of exposure, and on the y-axis, we have the risk ratio. So estimates that are less than 1 would suggest a decrease in live births and therefore an increase in lost pregnancies associated with exposures as they happen in the first, second, third, etc. gestational month. And I'd also like to draw your attention to those early gestational months, particularly because of biologic research suggesting that stressful events when they happen earlier in gestation are more likely to increase the risk of a lost pregnancy. And we use these models because they're really, really useful to help us rule out competing explanations. And they do so in 2 main ways. The first way is that the models use a month level lag structure. So confounding has to be co-occurring with deaths at the month level. So all the time varying confounders have to co-occur or happen in the same month as changes in police violence. The second way that they help rule out competing explanations is by using county level fixed effects. So we address time invariant county level confounders, such as residential segregation. We also include seasonality adjustment using a spline approach, and in sensitivity analyses, adjust for crime. Some of our descriptive results are first that the highest number of police-related fatalities in 1 month was 11 in the LA metropolitan area. And this area also had the most deaths over the study period. However, 40% of the included areas had only 1 incident of fatal police violence over this time, and most months in these areas had no deaths. Most of the included deaths were due to gunshot, and most of the deaths overall were due to gunshot. And then moving on to think about our first hypothesis or research question, each incident of fatal police violence that occurred during the 1st through 3rd months of gestation was associated with a small but statistically significant decrease in the number of live births, a 0.14% decrease, which would suggest an increase in lost pregnancies in these areas, in these cities and surrounding areas. So that's the overall association. And then our second research question was about whether these findings were consistent across maternal race and ethnicity. So first we find no association between increases in fatal police violence and live births among births to white women. However, we find that each additional incident of fatal police violence that occurred in the 4th, 5th, and 6th gestational months was associated with a 0.29% decrease in births to Black women. And we also observed similar decreases for Latina women for the 1st through 3rd gestational months, and for Asian women in the 1st through 6th gestational months. This work suggests, and these findings suggest, adverse population health consequences of fatal police violence extend beyond those who are directly harmed, and underscores for social epi the intergenerational nature of structural racism and its impacts on health. However, as you saw, we had a pretty small magnitude of effect, and I think there are a couple of reasons why the effect is so small. First, we used a really narrow definition of exposure so that we could rule out so many confounders. So we had to look at effects within counties, but we all know that there are some incidents of fatal police violence that might have a national level impact, and our models would underestimate those associations. We were also, because of the birth certificate data I had access to, only able to look at month level effects. So stronger associations might exist at the week level. And as I also showed, the exposure is pretty unevenly distributed across space. So even though most areas only had 1 death over the study period, extrapolating out our findings, these would suggest a 1.75% decrease in births in Los Angeles County, where there were 11 deaths per month at one time. So there's likely a lot of heterogeneity that we didn't, across space, that this study wasn't able to fully explore. But pulling back to think about this at a policy level, these findings support existing public health recommendations to take a preventative approach to police violence, because it would prevent not only those deaths, but also the health harms and implications of them. One example of this is the 2018 American Public Health Association policy statement that you should read if you haven't.
I think before you move on to your next study, because this is really interesting, and I know I have a lot of questions, I thought we could take a couple of minutes to see if people had, to let all of that sit and see if people had some questions about that study in particular. I know for me, and one thing that came up a little bit in the chat was, why did you use CBSA instead of, actually, so my interest is looking at even smaller levels. So looking at things that are happening at the census tract level so effects that are much more proximal. So wondering why you chose to look at events in such a large area.
Yeah, a few reasons, and it's a really good question. I'm glad you asked this. First, because the birth certificate data I have only had county as the lowest geographic unit of analysis. So we repeated our analyses at the county level and found really similar findings. But we also chose to present the CBSA level results as the main results, partly because we had less technical modeling difficulties with that approach, because the exposure is relatively rare across time. And so to minimize the months where there are 0 events, it helps to aggregate up to a higher level. And then just sort of more broadly, as I was sort of getting to at the end, it's kind of hard to think about what the appropriate geographic unit of analysis is for this kind of question. And it likely differs across different deaths. Some deaths have a national psychosocial impact, and some maybe receive a small, very localized coverage. And so it's something that research in this area broadly needs to kind of balance.
Makes sense. And why did you choose to study pregnancy loss in particular of all the effects?
Yeah, there is, so mechanistically and biologically, this and other areas of my work have looked at stressful events that happen during pregnancy as a sensitive period in the life course. And then pregnancy loss is particularly useful because it allowed that empirical estimation strategy that used like the environmental epi modeling of the live births and changes in the live births. But there's actually just like last week or the week before, some new work from Dana Goen at UCSF that suggests the hazard of preterm birth at the census tract level increases with incidence of fatal police violence also. So there's more work in this area, especially related to birth outcomes.
And there's a question from Dr. Aminawang about what the comparator was. So you note that there's a decrease in births or decrease in expected births. And what was that compared with?
Yeah, that's a great question. So it's compared with the average temporal trend over time within county, within CVSA.
So did you look at like previous years or previous months, or how did you
so the models take sort of an estimate of these average exposure changes over time and average trends in the birth outcome over time and links them together using a splined approach. So the comparison is to that like average temporal relationship, but not necessarily to like one referent year because it's like each additional increase in birth.
Great. And we have Dr. Howell is raising his hand. I don't know if you can unmute and ask your question. Maybe you can put your question in the chat because I don't know if you can do that. And one other question for you is you found the differences in the effect, the timing of the effect between Black women, Latino women, and Asian women. And I'm wondering what your theory is for why those differences exist and what might be going on there, because that was really interesting to see.
Yeah, frankly, I'm not sure why what you're saying is like the timing, the exposure in the 4th month for Black women was particularly relevant versus for Latino women, it wasn't the 1st through 3rd months. I'm not quite sure. And I think that is partly a gap in our like understanding of like psychosocial exposure during pregnancy and the relevant timings. But yeah, it's an open question to me.
Great. Well, we'll see if other questions come up by the end and if you want to move on to your next study.
Sure.
Thank you for introducing us to this.
Okay, so the second part of the presentation, I'll move from talking about these community level effects of fatal police violence to talking about the health harms of solitary confinement from the perspective of those who experience it. And this is also unpublished work. It's preliminary findings from an ongoing study about clustering of health burdens and solitary confinement that I'm working on with this wonderful research team. And as a background for those of you who might not be familiar with what solitary confinement is, it's a 23-hour-a-day lockdown in a prison cell with short, tightly controlled movements for showers, medical visits, or recreation. It's fairly prevalent, as some of the people that might be in this session know, with approximately 20% of those incarcerated in US prisons report being held in solitary confinement in the past year, half of whom were there for 30 days or more. And research on the mental health consequences of solitary have contributed to restrictions on its use. And the restrictions particularly for people with serious mental illness. And this, however, even in jurisdictions where there are restrictions on solitary for those with serious mental illness, the practice continues to isolate people without this serious mental illness designation. And so what this study set out to do was identify the multiple health burdens experienced by a sample of men in solitary confinement, and to describe how the conditions of solitary contribute to the development of new health problems and management of pre-existing health issues. And this study used in-depth interview data from 99 men in Pennsylvania within 2 months of their entry to solitary in 2017. The interviews lasted for an hour or an hour and a half and included a quantitative survey component. The interviewers were not allowed to interview those with capital cases or serious mental illness designation. But among the set of people that they were able to interview, there was an 80% response rate. And this represented 40% of all admissions to solitary during the study period. And to look at these data, we used a mixed methods approach. First, using a quantitative analysis of the survey, using latent class models to identify clusters of health conditions and demographic groups. And then we used those quantitative results to inform our qualitative component, where we use thematic analysis to code transcripts, develop themes, and then compare those codes and themes across the clusters that we identified in the quantitative portion. So addressing that first research question about patterns of multimorbidity in the sample, the latent class analyses indicated that there were 3 groups or clusters of men in the sample. Those that were relatively healthy, those with a higher burden of mental health problems, and those with a higher burden of physical health problems. In the relatively healthy group, which was most of the people, most of them were younger, less than 40 years old. About 64% of them were white, 35% reported a chronic disease, and 34% reported chronic pain. 23% reported a mental health diagnosis. And this is in contrast to a similarly aged, but different subgroup with higher burden of mental health problems. That included higher proportions of Black and Latino men. And 100% of this group reported a mental health diagnosis. And 96% reported anxiety or depression. 80% reported substance use disorder. There was also a high burden of schizophrenia. And then our last group was this group with a higher burden of physical health problems. These were more likely to be older men, mostly 51 years or older. About half of them were white. 94% reported a chronic disease. All of them reported chronic pain, and all of them reported substance use disorder. And so to answer our second research question about understanding how the conditions of solitary contribute to health burdens and disease management, we looked at those 3 groups that I just talked about across 4 themes. The first theme was about restrictions to daily living that kind of define some of the solitary experience. And these restrictions include restrictions on food and the feeding schedule, when people are able to exercise. And the group 1 that was more relatively healthy reported that those restrictions affected their weight loss, their sleep patterns, and that those weight loss and sleep patterns also had consequences for their physical pain that they just experienced kind of day to day. And those findings were shared broadly across the other two groups. But in addition, those in group 3 with the higher burden of physical health problems found that the restrictions on food also presented a problem for the special diets that they needed to manage chronic disease. And that those restrictions on exercise sometimes exacerbated their chronic pain. So to give you a sense of what I mean, someone in that third group said, I got acid reflux pain, gastritis. Right now, I haven't got my diet for days and I'm trying to get it. And I don't know what's going on. It's hard to, even from the block, it's hard to getting things. Imagine from down here in solitary, it's bad. Our second theme was about aspects of the physical environment and how those affected health. And so these ideas and findings were broadly shared again across all three groups. So the relatively healthy group, most people talked about concerns about temperature. The interviews were conducted in the summertime. People talked about extreme heat and improper ventilation. Also about mice and broken toilets and concerns about the quality of the tap water. And then those were shared reflections, but also the group with the higher burden of physical health outcomes talked about their severe chronic pain being exacerbated by some of the worn bedding that was available. So to that point about the water, this person from group 1 is saying, the water is disgusting. It's coming from a pipe that Abraham Lincoln might have helped put in. Our third theme is about isolated idle time. Respondents described how isolated idle time was spent worrying about family, arrival and departure from solitary and prison more generally. And even in the relatively healthy group, participants reported how isolation contributed to depressive symptomatology. There was for the group with a higher burden of mental health outcomes, they were particularly affected by isolated idle time because their pre-existing mental health conditions and especially their prior trauma heightened the number of panic attacks that they experienced and their depressive symptoms and their ability to manage their depressive symptoms. To give you a sense of that, I'll share this quote from someone in group 2 who says, I've been more sad, I cry more, and I feel like a failure. I feel like I've failed. This is like the bottom of the bottom coming to this place. I feel like a failure. This place reminds you of that all the time. There's no one really to talk to, so you're left to like talk yourself down. And then our fourth and final theme related to healthcare access in solitary confinement. And the relatively healthy group, even though they requested healthcare less than the other two groups, reported difficulties requesting healthcare and problems receiving wanted medications. And these two challenges engendered a pretty high degree of medical mistrust. And that mistrust was held across the other two groups as well. For the group with more mental health outcomes, they experienced delays receiving care and particularly delays receiving mental health care and had a pretty significant degree of distrust of the psychiatric care system in this context and in prison broadly. Group 3 with the higher burden of physical health outcomes talked about problems getting needed medical equipment and medications, and distrust of medical staff and some of the medications that were prescribed. So someone from group 3 to that point is talking about, I tell them that I need my asthma pump, and you got to argue with them to get it, to try to get it, all sorts of crazy things. It's like you have to throw a tantrum fit in order to get upstairs. And upstairs is, of course, to receive medical attention. And so our study kind of broadly documents persistent efforts that respondents made to maintain their health and to access healthcare, despite some of the pretty severe challenges posed by these conditions. We find severe health concerns and multimorbidity in the sample, even though our sample didn't include people with a designation of serious mental illness. And we also importantly find that there were health harms people reported associated with this experience, even among groups that we classified as relatively healthy. This suggests that restrictions on the use of solitary confinement for those with serious mental illness don't go far enough in preventing the harms of this experience. And it supports a growing consensus among public health and medical professionals, and increasingly, sometimes within departments of correction and policymakers, on reducing and eliminating solitary confinement. However, there are some limitations that should be noted of this study. So the first is related to our sample. Our sample is only in Pennsylvania and it's only men. And even among the sample of men in Pennsylvania, it only included about 40% of admissions to solitary confinement. And there could also be potential reporting bias and people's willingness either to share harms related to an external researcher. But on the other hand, several respondents were kind of reluctant to share vulnerable aspects of their health and especially their mental health. Do we want to ask questions about this, Louisa? I think you just unmuted.
I was just going to pop on and ask some questions, but if you have a couple more another implication slide, why don't you do that and then we can go to questions.
Okay, I mean, it's a just pretty brief takeaway from everything. Just sort of taking a step back, when I thought about kind of linking these two projects together, what I'd like for you to take away from this is that the criminal legal system is a multi-level and multifaceted set of exposures. And social epidemiology theories are particularly helpful in understanding their consequences for health equity. Public health researchers and practitioners have a role in improving data collection. The data that I used in my first paper depended on linkage across two flawed monitoring data sets. So on the death side, we need better monitoring of fatal police violence. And on the birth side, we need better monitoring of maternal exposure to the criminal legal system. But there's also a role for public health researchers in continuing to document these health inequities, and not because research should be necessary to prove what affected people and activists have been saying for a very long time, but because monitoring inequities is a metric to evaluate the conditions of policy that people live within. So exposure to inequitable or equitable policy, especially as policy change in this area is always emerging and changing. And lastly, I'd just like to say that there's a role for advocacy and activism among public health researchers and practitioners to change the policies that expose the populations we study to police violence and solitary confinement. Great, so thank you everyone for listening. I would be happy to talk about the second paper, the first paper, any broad general questions.
So thank you so much. This is really interesting. Both of the projects were super interesting. I had some questions about the second project, and I think as members of the audience also have questions, please put them in the Q&A or the chat. Overall, it really underscores what a horrible environment solitary is for people's health and mental health. So thank you for doing this work. I think it's really important to get that out there. Wondering, you mentioned in the beginning that people who have serious mental illness are not eligible for solitary. And then wondering, so who the people were, how do they define serious mental illness for that exclusion? Who are the people that you qualified as being having a high burden of mental health conditions?
Yeah, that's a really great question. And I'm glad that that is a piece of this that you took away, because it's part of this project that I've been reflecting on a lot. So yeah, the study didn't include people that were designated as having a serious mental illness. And the way that that designation works, at least in the state that we looked at, but also broadly, is it's a designation made by the departments of correction themselves. And so it, as you saw in our data, doesn't align with a medical diagnosis necessarily of a mental health outcome, particularly because we found in that group with a higher burden of mental health outcomes, people reporting schizophrenia or people talking about pretty severe levels of depressive symptoms. So things that I might consider to be serious mental health problems, but those findings and diagnoses aren't necessarily always consistent with the SMI designation.
Muted. A question from the audience. Somebody asked, how long were the individuals who were interviewed in the solitary study actually, how much time had they spent in segregation when they were interviewed?
Yeah, it's a good question. Because of this is a cross-sectional sample of a larger study. So people that were eligible to participate in our study were those that had entered solitary within the last 2 months. So it does include people who had potentially experienced solitary before, but this current experience was 2 months or less.
And earlier in the presentation for this study, you grouped the interviewees into 3 groups: a relatively healthy, higher burden of mental health problems, and a higher burden of physical health problems. And I was wondering, how did you group people?
Mm-hmm.
How did you decide which group they went into?
Mm-hmm. I'm sorry if you can hear my dog, by the way. So we used a latent class analysis approach where we took the quantitative data to try to understand across this broad spectrum of mental and physical health diagnoses and other demographic characteristics, like what of these variables hung together. And then we used like a AIC and BIC approach and some entropy measures to decide how many clusters we should keep and what fit the data the best. And also theoretically, this 3 cluster approach seemed to make the most sense.
So this was using the survey data?
Yeah. So this is the quant part.
Got it. And there's a comment that from somebody who worked in a supermax for men, who mentioned that the severely mentally ill were segregated from the population because they were also more violent when they would stop taking their medications, and really had there were issues with medication adherence and taking the medication. So that's really valuable insight from somebody who's been doing that work. And you also mentioned at the end, one possible limitation could be bias in terms of how people answered these questions. So I was wondering, who did the interviews? Who were the people conducting the interviews?
I'm so glad you asked that, particularly because I didn't conduct the interviews. So it was a research team that was 2 faculty members and I think 3 research assistants. One limitation of that group is that all of them are white, and as you saw, not the full sample was white. So there could be some differences reflected in what people are willing to talk about and who feels comfortable. I mean, even besides race, like this was an incredibly highly educated group coming in. And people might feel skeptical of sharing some of their most personal and traumatic experiences with someone who they know is going to leave, and who doesn't share likely some of the life experiences that they have had. So yeah, I think the question about bias and like what people are willing to talk about is sort of complicated because of both those differences and who is interviewed and who the interviewers were. Because it also could be the case that some people wanted to share findings with an external body, that people actually talked about in some of the interviews that they were just happy to have someone who wasn't from the staff to talk to. And so it's kind of complicated to think through that source of bias.
Great. And a couple of questions that have come up from the audience. So someone asked, there's a question actually from Dr. Aminawang about the current study, so we'll ask that first. But what variables from the quantitative piece were used to create the classes, and what were the group sizes?
Yeah, that's a great question. So because the sample included almost 100 people, so these percentages here are really close to actually the counts in terms of what the group sizes were. And the variables included it was a pretty, the survey included a pretty diverse set of health outcomes. Several types of chronic disease, including CVD, high blood pressure, diabetes, and then also a broad set of mental health diagnoses. But in addition to those like reported past diagnoses, there was also a self-reported health measure. And then there was, on the demographic side, we included age, race, and educational attainment. And so we had to, because we had this sort of like large K, small n problem where we collected so many variables and only had a sample of 99 people, we had to index a lot of those variables to collapse them to generate the clusters and meaningfully describe the data. So we collapsed those chronic disease diagnoses and collapsed some of the mental health diagnoses into mood disorders and like other psychiatric conditions.
And a question back about the first study, asking about what your conclusion was as to why the women in different racial groups had an increased risk. The question's about increased risk of mortality, but if I remember right, I think that this was about increased risk of pregnancy loss for those women. So it's not mortality for the women themselves, but pregnancy loss. So just if you could just emphasize your theory as to what's going on there and why these different groups are having increased risk of pregnancy loss after exposure to police violence.
Yeah, thanks. So we find in those race stratified models, just to kind of refresh your memory, that increases in fatal police violence were associated with increases in pregnancy loss for Black women, for Latino women, and for Asian women, but not for white women. And it aligns roughly with some of the ways we've been thinking as a research group about structural racism as it plays out in fatal police violence. These events likely have a traumatic impact for all racial groups, and actually some emerging research suggest that, but they have a particular racial salience for groups that experience higher levels of surveillance by police and fetal police violence broadly. And so I think that's how I understand the results. And that said, though, our available data that we had from the birth certificates didn't allow us to examine some of the nuance in those racial classifications. So for example, we don't have disaggregated Asian ethnicity data in the data set I own.
So we only have a couple of minutes left. So there were a couple of comments and then some questions about your future plans. One comment from Ms. Garcia was just that for some inmates that are at the end of life, there can also be severe emotional distress and people who are really left alone and left in their distress, even outside of solitary. And Dr. Wong just saying that she appreciates your framework, that the criminal legal system is multi-level and multifaceted in terms of exposure. And this really provides a strong basis for community organizing and advocacy, and agreeing just that it's challenging that all the qual interviews were done by people presumably that don't have lived experience of incarceration, and also that all were white, and how the race and structural racism play out in corrections and even in evaluating all of these things. And Mr. Harvey's asking about your plans for future research and any unanswered questions that you're hoping to explore more. I think this gives us all a lot to think about, and how we can, from our different vantage points as clinicians or scientists or advocates, do this work together. So what would you like to see moving forward?
Yeah, absolutely. Thank you so much, everyone. And I'm always looking for research collaborators, so please feel free to reach out and email me. So in my future work, I have a lot of studies running right now, but something that I really am excited about getting started is related to pre-pregnancy hypertension and understanding like multiple forms of exposure to the criminal legal system across the life course, and how that might help us understand racial inequities in pre-pregnancy hypertension and maternal mortality. As you could see from this, the two projects I shared, I'm interested in a broad range of health outcomes, but a particular passion of mine is birth and early life. So yeah, I'm looking forward to that work.
So I think we just have the last couple of minutes. I want to thank everyone for joining us today for the first SEICHE seminar, and remind you about our upcoming seminars. One is going to be April 22nd with Dr. John Eason. I'm going to share in the chat the Zoom link for that. And well, I can't seem to, let's see if I'll get the Zoom link to work. But after Dr. John Eason on May 20th, from 4 to 5, we'll have Dr. Liz Barnard joining us. So I'm going to see if I can pull up these Zoom links and put them in the chat. Here they are. But it would be great to have you all joining us for that. And thank you again, Dr. Jahn. This was really just fascinating research, and it's really encouraging to hear about the policy statements that are coming out and the work that we can all do together to hopefully mitigate some of these harms and change the way that we are, the criminal legal system functions.
Thank you so much. And thank you for facilitating, Louisa. I really appreciate being here. Thank you, everyone.
Thanks.